Welcome. In this session, we'll discuss the fundus findings in a glaucoma patient, particularly the optic nerve characteristics in glaucoma. We have discussed about history taking and anterior segment examination as well as gonioscopy in glaucoma patients in previous sessions. The term optic nerve is preferred over optic disc because whereas the term optic disc refers to only the visible surface area of the anterior portion of the optic nerve, the term optic nerve head refers to the three-dimensional structure of the anterior portion of the optic nerve, and glaucomatous damage to the anterior portion of the optic nerve head, as we shall see, is three-dimensional. Characteristic changes of the optic nerve head are the defining features of glaucoma, and in most glaucoma patients, the optic nerve head changes precede visual field loss. Before we go into examination of the optic nerve head, we will discuss about pathogenesis of glaucomatous optic neuropathy. The lamina cribrosa, which is continuous with the sclera, is the main support for the structures passing through the optic nerve, which include the axons of the retinal nerve fiber layer and the central retinal artery and the vein. The lamina cribrosa consists of a reticulated network of connective tissue beams with ports between the beams as seen here in this photograph, and through these ports pass the axons and the central retinal blood vessels. The beams are made up of connective tissue, mainly collagen. In normal eyes, the density of this connective tissue has been found to be lowest, with larger size of ports in between these beams in the superior and the inferior poles of the optic nerve head as compared to the nasal and the temporal regions of the optic nerve head. Through the larger ports in the center of the lamina cribrosa pass the central retinal blood vessels, and through the ports in the periphery pass the axons of the retinal ganglion cells. As we have discussed in the neuro-ophthalmology section, the arcuate fibers of the nerve fiber layer pass through the superior and the inferior poles of the optic nerve head to reach the optic nerve. Glaucomatous optic neuropathy begins with structural changes in the lamina cribrosa. Lamina cribrosa is said to be the primary site of damage, and damage to the axons of the retinal ganglion cells passing through the lamina cribrosa is said to be secondary to the structural changes of the lamina cribrosa in glaucomatous optic neuropathy. And this damage to lamina cribrosa is characterized by rupture of the connective tissue beams and coalescence and enlargement of the ports between the beams. Intraocular pressure is said to be the major risk factor for this damage to lamina cribrosa, as intraocular pressure causes stress and strain to the lamina cribrosa being the weakest portion of the sclera. In normal tension glaucoma, associated factors may make the lamina cribrosa susceptible to damage at a lower intraocular pressure. As we have mentioned, following the structural alteration in lamina cribrosa, there is progressive degeneration of retinal ganglion cell axons and associated glial cells and blood vessels. Retinal ganglion cell axonal damage begins at the level of lamina cribrosa, particularly in the superior and inferior poles of the optic nerve head, where the lamina cribrosa is the weakest. Posterior and lateral bowing of the weakened lamina cribrosa causes misalignment of the fenestra or the ports of the lamina cribrosa, compressing the axons of the retinal ganglion cells passing through this fenestra. Because of this compression of the retinal ganglion cell axons, there is blockade of orthograde and retrograde exoplasmic transport within the axons of the retinal ganglion cells at the level of lamina cribrosa. Because of blockade in retrograde exoplasmic transport, neurotrophic factors such as brain-derived neurotrophic factors, which are taken up by the terminals of the axons of the retinal ganglion cells, are prevented from reaching the cell body of the retinal ganglion cells, and this leads to apoptosis of the retinal ganglion cells and their axons. Contributing pathogenic factors to glaucomatous optic neuropathy are insufficiency of optic nerve head blood supply, which is demonstrated by fluorescent angiographic studies and which especially occurs in normal tension glaucoma. Low cerebrospinal fluid pressure can also contribute to pathogenesis of glaucomatous optic neuropathy by increasing the translaminar pressure gradient. Translaminar pressure gradient is the difference in the intraocular pressure and the cerebrospinal fluid pressure acting on opposite sides of the lamina cribrosa. And low CSF pressure has been demonstrated in patients with open-angle glaucoma and normal tension glaucoma. CSF pressure has been found to be higher in ocular hypertension patients. There can also be transsynaptic degeneration of lateral geniculate nucleus and occipital cortex. Examination of the optic nerve should preferably be performed on the slit lamp with a fundus lens such as the 60 diopter, 78 diopter or the 90 diopter lens. These fundus lenses provide a stereoscopic view, but the view is inverted, which is very important to remember. So the superior pole of the optic nerve will appear to be inferiorly located, and the inferior pole of the optic nerve will appear to be superiorly located. Similarly, there is a right-left inversion also. The diameter of the optic nerve in millimeters can be measured by adjusting the height of the slit beam and applying a correction factor of 1.1 when we are using a 78D lens and 1.3 when we are using a 90 diopter lens. When we are using a 60 diopter lens, we do not need to apply a correction factor to the measured length. The average diameter of the optic nerve is approximately 1.5 mm to 2.2 mm, and the measured diameter is underestimated in myopes and overestimated in hyperopes. The direct and indirect ophthalmoscopes should preferably not be used for ONH examination in glaucoma patients and suspects. This is because with the direct ophthalmoscope, we do not get a stereoscopic view to detect subtle features on the surface of the optic nerve. And with indirect ophthalmoscopes, we get a very magnified view of the fundus. The normal optic nerve has a central depression called the optic cup, as seen here in this photograph, which is devoid of RGC accents, and the entire cup appears pale, and normally pallor within the optic nerve is restricted to the cup. And the tissue between the outer margin of the disc and the outer margin of the cup is the neuroretinal rim through which pass the RGC axons. The neuroretinal rim appears orange-red in color because of associated capillaries. And tracing the curvature of both large and small blood vessels on the optic nerve may help in determining the inner edge of the neuroretinal rim. So as we see here in this photograph, tracing the curvature of both the large and the small blood vessels on the optic nerve help us in determining the inner edge of the neuroretinal rim, because there is a bend in these blood vessels at the inner edge of the neuroretinal rim. In most normal eyes, the optic nerve is vertically oval and the cup is horizontally oval. So normally the horizontal cup disc ratio is more than the vertical cup disc ratio. If the vertical cup disc ratio becomes more than the horizontal cup disc ratio, suspicion for glaucoma increases. The larger the optic nerve area, the larger is the physiological cup area. And this is very important to understand and remember. Cup disc ratio in normal individuals has been shown to be inherited, symmetrical in either eye, and does not vary much with age. Cup disc ratio should not be the only criterion to distinguish glaucomatous and non-glaucomatous optic nerve heads, and this is very important to remember, because by doing so we are not considering the size of the optic nerve head. As we have seen, normally large optic nerve head can have a larger cup and a larger cup disc ratio, but also because there is significant inter-observer variability in assessing the cup disc ratio, and measuring only the cup disc ratio misses focal neuroretinal rim loss. Clinical signs of glaucomatous optic neuropathy include diffuse neuroretinal rim loss, focal neuroretinal rim loss, retinal nerve fiber layer defects, disc hemorrhages also called splinter hemorrhages, and peripapillary atrophy. There are also other clinical signs of glaucomatous optic neuropathy which we will also discuss. Diffuse neuroretinal rim thinning with generalized enlargement of the cup is a common feature of a glaucomatous optic nerve, but it is often difficult to diagnose glaucoma based on a single examination detecting this sign in the absence of previous photographic record to demonstrate enlargement in the size of the cup. In the initial stages of glaucoma, increase in the size of the cup may progress faster than the increase in the area of pallor within the cup, leading to cup-pallor discrepancy, and this may lead to inability to detect neuroretinal rim thinning. And in this situation, as we have mentioned, bending of the optic nerve blood vessels at and stereoscopic appreciation of the inner margin of the neuroretinal rim help us to avoid missing NRR thinning. In this session, all diagrams of the optic nerve will be that of the right eye. So this will be the superior quadrant, this will be the inferior quadrant, this the nasal quadrant, and this the temporal quadrant. Normally, in the absence of disc size asymmetry between the two eyes, the difference in the cup disc ratio between the two eyes should not be more than 0.2, and this is a very important figure to remember. And as we have mentioned, normally large cup disc ratio is inherited. Examination of other family members may help in determining whether a large cup is inherited or acquired due to disease. Features of optic disc in end-stage glaucoma as seen here in this photograph include absence of neuroretinal rim tissue, cupping extending up to the outer margin of the optic nerve head, blood vessels bending at the outer margin of the optic nerve head, deep posterior bowing of the lamina cribrosa and lateral undermining of the disc margin, the so-called bean pot cupping as shown here in this diagram, and pallor of the entire optic nerve head. Reversal of cupping has been described in infants with congenital glaucoma following surgical reduction of the intraocular pressure within the first year of life, and this occurs because of increased elasticity of sclera and lamina cribrosa in this age group. Reversal of cupping represents mechanical effect of reduction in the intraocular pressure and does not represent an increase in neuroretinal tissue. Focal thinning of neuroretinal rim or notching is very characteristic of glaucomatous optic neuropathy and is specifically found in the inferior and the superior poles, or more specifically the inferotemporal and the superotemporal poles of the optic nerve head as shown here in this diagram. In this diagram we see the thickness of the neuroretinal rim has decreased in the inferotemporal pole of the optic nerve head. Normally, the thickness of the sectors of the neuroretinal rim are in descending order: inferior, superior, nasal and temporal sectors, which is called the IS-NT rule. And discrepancy in this order increases suspicion for glaucoma. But this rule is not highly specific, and physiological discs may also disobey the Eisen rule. But comparing the inferior and the superior rims directly is said to be more specific and is called the IS rule. Thinning of the vertical sectors of the neuroretinal rim leads to a vertically elongated cup and increase in the vertical cup disc ratio, and thinning of the inferior sector of the neuroretinal rim as shown here in this diagram occurs more commonly than the thinning of the superior sector of the neuroretinal rim, and this leads to violation of the IS rule, which states that normally the inferior sector of the neuroretinal rim is thicker than the superior sector of the neuroretinal rim. We must remember here that, as we have mentioned, when we are examining the disc on the slit lamp with a fundus lens, the image is vertically inverted so that the inferior pole appears to be superiorly located and the superior pole appears to be inferiorly located. Following thinning of the inferior and the superior sectors of the neuroretinal rim, thinning of the temporal sector of the neuroretinal rim occurs, and thinning of the nasal sector of the neuroretinal rim is the last to occur. Extensive focal thinning of the neuroretinal rim with exposure of the lamina cribrosa up to the margin of the optic nerve head, which is called an acquired optic disc pit, is highly suggestive of glaucoma. Saucerisation of the optic nerve head as shown here in this diagram is another sign of glaucoma, and saucerisation can be focal or diffuse. In an area of saucerisation, there is shallow enlargement of the cup effacing the neuroretinal rim, with the central portion of the cup appearing pale, but the area of pallor not extending to the area of enlargement of the optic cup. And this region of effaced neuroretinal rim initially retains the original orange-red color of the neuroretinal rim before becoming grayish in color. And any blood vessel passing through the area of saucerisation bends at the outer margin of the saucerized area. Loss of retinal nerve fiber layer is another characteristic feature of glaucoma. Normally, the retinal nerve fiber layer appears as fine striations radiating from the optic nerve head, brighter in the superior and inferior sectors as compared to the nasal and temporal sectors. The striations are visible only when the thickness of the retinal nerve fiber layer exceeds a critical thickness. And the retinal nerve fiber layer is best viewed with a green filter, also called a red-free filter, which is very important to remember, on a wide slit lamp beam and one of the fundus lenses. Diffuse RNFL loss is more common than focal RNFL loss, but is also more difficult to detect clinically. Diffuse RNFL loss appears as a reduction in the difference in brightness between the superior-inferior sectors and the nasal temporal sectors of the RNFL. Focal RNFL loss appears as wedge-shaped dark areas emanating from the optic nerve head margin as shown here in this diagram. And location of these wedge-shaped RNFL defects correlate strongly with locations of focal NRR thinning or notching and visual field loss. These wedge-shaped RNFL defects may be preceded by splinter hemorrhages, which we will be discussing, and there can be slit-like defects in the retinal nerve fiber layer normally, but these slit-like defects do not reach up to the ONH margin. Retinal nerve fiber layer or splintered hemorrhage appears as a linear red streak on the surface or near the disc as seen here in this diagram, and it is more commonly found in normal tension glaucoma as compared to high tension glaucoma, and it can be very subtle and easily missed during examination. It usually resolves over several weeks, and the portion of the hemorrhage over the disc resolves first, so during examination only the extrapapillary area can be seen. Retinal nerve fiber layer hemorrhages can be followed by development of a localized RNFL defect, focal notching of the neuroretinal rim, and a visual field defect corresponding to the notch and the localized RNFL defect. RNFL hemorrhages are considered as an important prognostic sign of development or progression of glaucomatous visual field loss, and patients with RNFL hemorrhages need close follow-up and repeat investigations. However, retinal nerve fiber layer hemorrhages are not found in sectors with complete loss of retinal nerve fiber layer and neuroretinal rim. Other causes of similar looking hemorrhages include diabetes mellitus, posterior vitreous detachment, retinal venous occlusion, and anticoagulant therapy. Atrophy of the peripapillary retina is another clinical sign of glaucoma. Normally, peripheral to the neuroretinal rim, there is a thin white rim of sclera called the scleral lip between the optic nerve and the choroid, present uniformly for 360 degrees around the optic nerve head. And peripapillary atrophy, if present, lies peripheral to the scleral lip. And two types of peripapillary atrophy have been described. One is the alpha zone atrophy, in which there is an area of irregular hypopigmentation and hyperpigmentation of the retinal pigment epithelium, and alpha zone atrophy can be found in both glaucomatous and non-glaucomatous eyes. Beta zone atrophy, as represented by this area in this diagram, when present lies central to the alpha zone. So this is the beta zone which lies central to the alpha zone. And beta zone atrophy represents atrophy of the choriocapillaries along with retraction of the retinal pigment epithelium from the margin of the optic nerve head. This diagram shows the retraction of the retinal pigment epithelium from the optic nerve head margin and atrophy of the choriocapillaries near the optic nerve head margin. Because of this atrophy of choriocapillaries and retraction of retinal pigment epithelium, large choroidal vessels and sclera become more visible in an area of beta zone atrophy. Beta zone atrophy is more commonly found in glaucoma patients as compared to non-glaucomatous individuals. Unlike alpha zone atrophy, which is found in both glaucomatous and non-glaucomatous individuals, beta zone atrophy can also be found in myopic eyes due to a tilted scleral canal. And the location of peripapillary atrophy corresponds to the sectors of neuroretinal rim loss. Peripapillary atrophic areas should not be confused with gray crescent found in temporal and inferotemporal periphery of the neuroretinal rim in many normal eyes. Other optic nerve changes in glaucoma include deepening of the cup, which may be the only sign of early glaucoma in some patients. In advanced glaucoma, deep excavation of the cup leads to exposure of the lamina cribrosa and its pores and striations. The striations represent the laminar beams and the pores lie between the laminar beams. Larger pores are often found in glaucomatous eyes and this is called the laminar dot sign, but striations are said to be more suggestive of glaucoma as compared to the pores. Nasal displacement of the central retinal blood vessels, as shown here in this diagram, occurs with significant enlargement of the optic cup. So this is the temporal aspect of the optic disc and this is the nasal aspect of the optic disc, and with enlargement of the optic cup, the central retinal blood vessels shift nasally as they maintain their position adjacent to the inner rim of the nasal sector of the neuroretinal rim. Bearing of circumlinear vessels, as shown here in this diagram, can also be found with significant enlargement of the optic cup. The circumlinear vessels arise from the central retinal blood vessels, curve along the inner margin of the neuroretinal rim and pass temporally towards the macula. When bared, these circumlinear vessels appear to hang across the optic nerve head without support from the adjacent neuroretinal rim. In the Bayonetting sign, there is an apparent discontinuity of a blood vessel as shown here in this diagram, as it disappears in the excavation of an enlarged cup before re-emerging at the visible margin of the optic nerve head, thus appearing like a bayonet of a rifle. So nasal displacement of central retinal vessels, bearing of circumlinear vessels and bayonetting sign are said to be the vascular signs of glaucoma. Glaucomatous disc damage can be graded either with the cup disc ratio system, which takes into account only the vertical cup disc ratio, or the DDLS, that is the disc damage likelihood scale system developed by Spithe. In the DDLS system, the disc is graded into 10 grades of severity, taking into account the rim disc ratio, so it is not the cup disc ratio, and the rim disc ratio is considered at the site of the narrowest rim width, and this accounts for the first 5 grades, in which the rim disc ratio at the site of narrowest rim width varies from 0.4 to less than 0.1. But if the rim is absent in a sector of the optic nerve head, the circumferential extent of the area of absent rim is considered to grade the disc from 6 to 10, with the circumferential extent varying from less than 45 degrees to more than 270 degrees. Size of the disc is also considered, making the DDLS system more reliable than the CDR system, and the grade determined on the basis of these two criteria is decreased by 1 when the disc is less than 1.5 mm in diameter, increased by 1 if the disc is more than 2 mm in diameter, and increased by 2 if the disc is more than 3 mm in diameter. And the DDLS score can be plotted longitudinally over time, as shown here in this diagram, to show the rate of progression of glaucomatous optic nerve damage. Since in many situations findings on clinical examination and investigations between normal individuals, glaucoma suspects and glaucoma patients overlap, detecting longitudinal changes over time in optic disc appearance and visual field loss, which we'll be discussing in the next session, is of utmost importance to establish diagnosis in a glaucoma suspect or to establish progression in a patient with a prior diagnosis of glaucoma. And this detection of longitudinal changes in the optic disc appearance can be done by drawing the surface topography of the optic nerve head at every visit. Better still, taking photographs, preferably stereoscopic photographs, enables detection of subtle changes in optic nerve head topography. But photographs do not give quantitative information of the amount or the rate of progression of neural loss, which are given by investigational modalities like automated perimetry and OCT, which we will be discussing in subsequent sessions. Differentiating glaucomatous optic neuropathy from other optic neuropathies is important. Other optic neuropathies which can be mistaken for glaucoma include anterior ischemic optic neuropathy, particularly the arteritic form, and compressive optic neuropathy, and these two entities have been described to have cupping resembling glaucoma. In glaucoma, as shown here in this diagram, the neuroretinal rim becomes thin and retains its original color in the thinned area. But in other optic neuropathies, the neuroretinal rim becomes pale, as shown here in this diagram, which shows sectoral rim pallor. And as a result, the area of pallor becomes more than area of cupping. And in non-glaucomatous optic neuropathies, the cupping does not increase in size on longitudinal follow-up over time. And this clinical differentiation between glaucoma and non-glaucomatous optic neuropathies is very important. However, pallor of neuroretinal rim can occur in a few cases of glaucoma after an episode of acute rise in intraocular pressure, such as following an acute attack of angle closure glaucoma. Optic disc drusions can show visual field defects resembling visual field defects of glaucoma, but with optic disc drusen, optic nerve head appears full without a cup. And features of myopic disc, as shown here in this photograph, may make it difficult to detect glaucomatous changes in myopic disc both on ophthalmoscopy and visual field analysis. And these features include distortion of temporal neuroretinal rim because of oblique insertion of the optic nerve, a larger optic nerve head, a large and a shallow cup, and peripapillary crescent atrophy and or staphyloma. Findings in vitreous and retina can indicate causes of secondary glaucoma, and this includes inflammation and hemorrhage in vitreous cavity, and in the retina, retinal venous occlusion, diabetic retinopathy, retinal detachment, tumors, and choroidal effusions. To recap the salient points, characteristic changes in the optic nerve head are the defining features of glaucoma and usually precede visual field loss in glaucoma. Lamina cribrosa is considered to be the primary site of pathology in glaucoma, which secondarily results in damage to the axons of the retinal ganglion cells. Both mechanical and vascular mechanisms are the most well accepted mechanisms of damage in glaucoma. The lamina cribrosa is the weakest area of the sclera, and within the lamina cribrosa, the inferior and the superior poles are weaker than the temporal and the nasal poles, as a result of which the arcuate fibers of the retinal nerve fiber layer are most susceptible to damage in glaucoma. The optic nerve should preferably be examined on the slit lamp with fundus lenses, which provide both a stereoscopic and a magnified but an inverted view of the fundus. The normal optic nerve head has a central cup which is pale in appearance and a peripheral neuroretinal rim which is orange-red in color. The quadrants of the neuroretinal rim in decreasing order of thickness are inferior, superior, nasal and temporal quadrants, which is represented in the isn't rule. And the margin between the cup and the neuroretinal rim can best be determined by observing the bending of the blood vessels of the optic nerve head and stereoscopic appreciation. Cup disc ratio should not be the only criterion to diagnose glaucoma because it depends on the size of the optic nerve head, with a larger optic nerve head having a larger cup disc ratio even if normal. And the clinical signs of glaucoma include diffuse loss of neuroretinal rim with enlargement of cup, focal loss of neuroretinal rim which is also known as notching, wedge-shaped focal and diffuse loss of retinal nerve fiber layer, retinal nerve fiber layer hemorrhages which are also called splintered hemorrhages, peripapillary atrophy, particularly beta zone atrophy, nasalization of central retinal blood vessels, bearing of circumlinear blood vessels, bayonetting of blood vessels, and laminar dots and stria. In glaucomatous optic neuropathy, there is thinning of the neuroretinal rim, but the neuroretinal rim retains its original orange-red color. In non-glaucomatous optic neuropathies, the neuroretinal rim becomes pale. Since deterioration of the optic nerve status is a crucial sign of progression of the disease, longitudinal recording of optic nerve appearance over time, preferably with stereoscopic photographs, is recommended. And the DDL score is helpful in grading the disc and also helps in determining the rate of progression of the disease. Thank you for listening.